Good afternoon and welcome to the HIMSS NCA webinar series. Our May event here is on consumer and patient engagement, and we are very happy to have you all here today. Next slide, please. All right, I'm Mandy Peckham. I'm the HIMSS NCA program chair, and this is the last of our spring series, and we're ending it with a bang here. We've got an excellent panel and moderator ahead to talk to you about consumer and patient engagement. But before we do that, just a couple of quick housekeeping things. Next slide. All right, so we're going to continue our webinars through the summer. We have announcements coming up soon, but expect to see some fireside chats, some joint organizational events, and some agency briefings. That'll be a little bit different than our normal panel discussion, but that'll be our summer lineup of webinars. So stay tuned for those announcements. Next slide. A huge thank you to our corporate sponsors, Cerner and ServiceNow. We are very thankful for their support, both for our webinars as well as our upcoming fall program where we hope to be back in person. And then one other quick note, Dan Bloom, our HIMSS NCA chapter advocate and board member, asked me to ask you, our members, to be on the lookout for an email that he will send out soon around a HIMSS overview that highlights HIMSS policy pillars that focus on connected health, cybersecurity, and data privacy and interoperability, and the associated policy priorities and advocacy engagement opportunities. This way you can also make the most of your HIMSS membership, and you'll get to see some details come out from Dan very soon, so be on the lookout for that email. Next slide. All right, we'll get to the meat of our discussion. I want to introduce our moderator, Sam Lampson, who is the Vice President of Interoperability at Cerner, and he's kind enough to moderate this awesome panel today. Sam, I'll turn it over to you.
Thanks so much, Mandy. I'm excited to be with the chapter today, and I'm thankful for the opportunity to moderate this discussion. We really do have an all-star panel here today. I'm going to quickly go through names and titles, then I'm going to hand it over to the panelists to do a brief introduction, a couple minutes on themselves, and then we'll move into more of a guided discussion for the rest of the talk. And as we go along, it'd be great to get any questions from the audience, from the listeners, to come through on the chat, and Mandy will help feed those to me, and hopefully we'll get some more interactivity. So just to go through in alphabetical order, Lorraine Du is the Policy Advisor for Health Informatics and Interoperability Group at CMS. We also have with us David Mazik, IT Product Owner for the Department of Veteran Affairs. Colonel Kevin Peck, who's joined us early in the morning from Hawaii, the Chief Information Officer in the Hawaii Market for Defense Health Agency. And then Aaron Sieb, the Chief Strategy Officer at Onyx Health. And with that, I'll hand it over, starting with Lorraine, to have the panelists introduce themselves.
All right, good morning. Thanks so much. And it seems like the name of my office kind of takes up the entirety of what I might introduce, but essentially the Health Informatics and Interoperability Group at CMS is focusing on the policy perspective of interoperability and the use of emerging standards for promoting what you're talking about today, which is patient access to their information. That's really at the heart of what we've been trying to do, both across industry as well as within the Medicare fee-for-service program. So we're trying to connect the dots across the healthcare ecosystem for the exchange of information. And that's really our reason for living and our reason for being in the agency. And we coordinate across different federal agencies, as well as within other offices, to make sure that they are really focused in on interoperability and with the use of APIs and implementation of FHIR, with this laser focus on patient access to their data, as well as on the exchange of data with payers and with providers. So I'll leave it at that.
Thanks, Dave.
Good morning, everyone. So Dave Mazik, Director of the VA Lighthouse API program. This discussion is really so aligned with everything we do on a daily basis. Our program really aims to put high impact applications in the hands of veterans, to put them in control of their data, and making their data accessible in standards compliant APIs is really the best way we can ensure that we get the most adoption there and the most choice. So again, thanks in advance, and I'm looking forward to the talk.
Colonel Peck.
Colonel Peck.
Hey, good morning, y'all. So, hey, first of all, don't feel too bad for me. It's sunny too, and it'll probably be 81, nice and breezy and sunny today. And I've been getting up at this time for the last 30 years, so no problem. I'm actually in a little bit of a unique position right now. I'm triple-hatted out in Hawaii. I'm the CIO at Tripler, and then, like we said, the CIO for the Hawaii health market, which takes into account all of our Air Force and Navy facilities on islands also. And then I work for the Theater Medical Command, which provides the operational medicine support that Cerner will also be moving into later on for the rest of the Indo-Pacific. So excited to be on here. One of the unique things we have is we actually have a VA clinic on grounds with us, with a number of clinics embedded in Tripler Army Medical Center. And we'll talk a little bit about that moving forward. But happy to be here and appreciate the invite.
Yeah, and my name is Aaron Seib. I'm the Chief Strategy Officer at Onyx. But more importantly, I think anyhow, for this conversation is I'm a family caregiver for a child with special needs. And honestly, at the end of the day, I think we're all here. Like everyone I've worked with over the last decade, since the formation of the ONC, has really been focused on how do we get data into the hands of consumers, beneficiaries, servicemen, veterans, so that they can enable themselves to be better participants in their care. And we can talk about standards and technology. That's my background. I was a semantics interoperability guy for the NCI when my son was diagnosed with autism. But really, having the technologies in a highly regulated environment and being able to run 300 clinical trials globally, but still not being able to get my son's data out of Johns Hopkins University is what drove me here. And it's what I think drives a lot of people, including the great people that are leading this conversation. I hope I can support.
Thanks, Aaron, and thanks, panelists, for the introductions. I know everyone is familiar with Cerner, but as it relates to today's events, we have been strident supporters to end information blocking and remove the barriers to preventing interoperability, especially for patients. And we continue to look for ways to support our federal government in other ways, enriching claims, supporting the consumer experience strategy, research, and public health. Cerner is proud to be supporting the modernization of the VA, DoD, and U.S. Coast Guard electronic health records. The Department of Defense is continuing to move forward full speed ahead with MHS Genesis, live at over 600 military treatment facilities across 17 states, over half of the continental United States is covered at this point. While not yet operational in Hawaii, as Colonel Peck mentioned, MHS Genesis is planned to be operational at Tripler later this year. The VA's EHR remains on track. The system is now operational and at its first site. In March 2021, VA Secretary McDonough announced a strategic review of the EHRM program, which we strongly support, and we continue to provide VA the data they need to inform any decisions that need to be made during the review. And with that, let's go ahead and jump into the questions for the day. So each of your organizations has a very patient-centric mission. And I loved Aaron's personal spin on that. As a parent of children with special needs as well, I feel very similar. It's such a high priority in ensuring that every service member, their beneficiaries, and veterans have exceptional experience at every stage of their care and their health. So to kick off, I want to let the listeners in on a brief introduction to the federal health landscape. Currently, over 9.5 service members and military beneficiaries, as well as 9.1 million veterans receive care within the respective health systems. And patients also receive care from community providers outside of those health venues. And Colonel Peck mentioned kind of both his dual role with the military treatment facility, as well as kind of the CIO of the outpost, the island-based other facilities. And so, Colonel Peck, you represent this microcosm of how this all works for the military. And I wonder if you could give a brief overview of the Tripler Army Medical Center and the other operations you have, as well as the and how it integrates with the island community and care providers.
Yeah, no, absolutely. So Tripler's the only level 2 trauma center from the Department of Defense side once you get outside the west coast of the continental US. And there's also, the Air Force has a couple of large ambulatory clinics here along with the Navy. And then of course we have stuff in Korea and Japan. And so again, what makes us a little bit unique from a lot of the other DoD medical treatment facilities is the fact that the VA here is co-located on our grounds. So I walk out the back door of my hospital straight into their facility. And they have 3 clinics currently inside of Tripler. And as you mentioned, in September 25th is our go live date for Genesis. We've already built in a number of their clinics, especially on the behavioral health side, into our build for Genesis, so that they'll be completely integrated once we go. They're going through the training with us, the go lives, et cetera. And so it kind of represents a unique opportunity, not just for us, but also all of DoD to help figure out exactly how we're going to finish integrating the VA EHR and the rest of the care that they provide with the facilities, especially in a location where we pass patients back and forth pretty often between the VA clinic and our hospital, and then of course back again to them. The one thing that does give me a little bit of pause when you talk about uniqueness is, for those who aren't aware, overseas dental work is done on pediatrics in DoD. So in CONUS, if you have a child, your wife, they go downtown, your husband, whoever goes downtown to get their care. When you're overseas, the pediatric side of the house takes care of all the exceptional family member program patients. We don't send those downtown. And so we're trying to figure out how to build that into the Dentrix portion of Cerner to ensure that we've captured everything that they do, because what they do is, it truly is unique. Going back to, one of the other panelist members, a second ago about his child, we have 35-year-old highly autistic kids that come in that they have to essentially hit them with a little bit of sedative on the way in the door so they can settle them down and then do the rest of the work that they need to do from the pediatric dental side. So that's where we stand.
Colonel Peck, building on kind of that, the lay of the land and how we think about the federal healthcare space. About 50% of veterans find care within the VA system, and I know the percentage of in-house care is higher for service members, but there's still a huge amount of care happening outside in the community. So even if the interoperability is really good between DoD and VA, which is the goal, facilitated by the Joint Health Information Exchange and supported by the CMS interoperability mandate, that really leaves a lot of care outside of those venues of care under consideration as a real interoperability challenge. So starting with Colonel Peck, but this is open to really all of the panel. What are some challenges that you've faced at Tripler and elsewhere with data exchange that's impacting how patients experience and are engaged with their care across the continuum? So
we were actually doing better a few years ago, just before I got here, and I actually experienced it as a patient because 2 years ago I had 3 major joint surgeries done, and they were specialized. They had to be done down to Straub, which is one of the larger health organizations within Hawaii. At the time that I was going through my pre-op, we had a homegrown system that they could send my images down, send doctor's notes back and forth, et cetera. But when DHA came in and stood up their JHIE that we're all required to participate in now, we had to turn our local solution off because there was a vulnerability that was found. And so now we only share electronically records with 3 of the major healthcare organizations here on the island, and Straub and a few others. Were back to where when I actually had my surgeries, I had to take a copy of my images, take all my doctor's notes, everything else, hand carry them down to the Straub facility, and then hand carry all the post-op notes and pharmaceutical, et cetera, back up to Tripler. And they got scanned into the system by being put directly into the EHR system. So of course they're not searchable now. And so there's still a struggle there. I think that most of the facilities here in Hawaii and the organizations are moving towards joining the JHIE, but we're just not quite there yet.
Anything the other panelists would like to add on that question about just the broader interoperability with community and within the federal government?
You know, just a lot of the veterans I work with, my brother's a veteran, you know, my family, a lot of vets, you know, just being able to, the CHOICE Act really enabled us to get care from someplace when we needed to, that wasn't being provided to us locally by the VA. And being able to think about the future where an interoperability platform where we're all using the same standards and, you know, what Kevin's talking about, I'm sorry, Colonel Peck is talking about. That's why a lot of the hard work we're doing today, you know, taking formerly scanned documents that don't even have the service member's ID on it, trying to figure out how to turn that into computable information. It will pay off for the people who are serving us today. I think it'll pay off for my son when he's 35. So there are a lot of struggles. And I think anyone who says otherwise is sugarcoating it. Every interoperability project, when we're taking legacy data and trying to transform it into interoperable information, like the heavy lift that Cerner's been doing, especially in new domains, dental, vision, you know, paid claims information, CMS led the way there. It took us 5 years to go from the idea to what I'm sure Lorraine's going to share about Blue Button 2.0. So we've really accelerated that process, but I think that, you know, in the long run, all of us, you know, it's going to help ourselves, it's going to help our families, it's going to help our country.
Yeah, and just to add on to that, with the Blue Button, there's two pieces. One is what the Blue Button offers to the Medicare beneficiaries, which is, you know, the main part is the ability to download, if you choose, your Part A, which is your hospital data, Part B, which is your physician data, and then Part D, which is pharmacy, into an application. And right now there are I think there's 61 or 68 applications, and they're pretty diverse. So if anyone, you don't have to be a Medicare beneficiary to go on. Anybody can go on and see what the apps are that are available. But there's a whole range of them. So you can download your claims data. You can also download an app where you can get incentives for certain behaviors. And that's a separate topic, which I think is really interesting. It's a good thing. I'm very, you know, optimistic about that. The other important thing that I think apropos of this conversation is where we provide to accountable care organizations data that providers can share, the same claims data for that whole continuity of care issue. So the Colonel was talking about the difficulty in having to get, you know, his records, take them to one place, take them to another place. Now they're not shareable. The attachment information is a separate conversation, but we provide, again, the Part A hospital, provider, and pharmacy data to a group of providers for the specific purpose of coordinating care, so that all those doctors within that group can share that information, and they share it within their electronic health record. But the purpose behind the interoperability rule that we published last May, which is going into effect in July, was so that patients would have their data from their payers and be able to have that on an app, and be able to also share that, or at least, you know, show it to a provider for the purpose of coordinating their cares. And then that would also be able to conceivably be uploaded to an EHR in time. What we don't yet have is sort of the three legs of the stool, where the payer and the provider and the patient are all seamlessly exchanging that information. And that's sort of, you know, the next phase of all of this, when we have the standards all talking to each other with the same terminology.
And, you know, Lorraine, just to tack on to that, my dad is using Blue Button 2.0, right? He's authorizing the sharing of it with me, so I can help coordinate his care remotely,
Exactly.
right? I can call my dad up and say, hey, Dad, I know you think he's a quack, but that cardiologist has an appointment with you today. You ready to go? Do you need me to come pick you up? right?
Yep,
And that is
exactly.
that is the kind of enablement I talk about, right? Like,
Yep,
if my dad and his dad never had that opportunity, right? And they lived like
exactly.
within 3 doors of one another.
Yep,
If it wasn't for my grandmother, my grandfather probably never would have gone to get care. So now I'm doing that for my dad, but I
yep,
couldn't do it with all the work that CMS has done and the app developers, and that's why
exactly.
we do this.
Yep,
Yeah, and just
absolutely.
to add on, I'd never heard of it. So that's one of the things I like about these panels and sitting in on some of these sessions, the blue button piece, just because it's not in the realm of, what I do right now. But from, my parents' standpoint, who are in their late 70s, I went online and looked it up, while you guys were talking here. And so now I'll definitely pay attention to this, utilize it, or
Mhm.
have them utilize it. So yeah, it looks like a great tool that you guys are doing a lot with.
Yeah, well, and just like a fifth or fourth or sixth tack on, what I find interesting about the apps that have decided to become sort of blue button enabled is that it's not just the data dumps, it's also some of the incentive programs or helping you pick a Medicare Advantage plan, so that of the 60X that are available, it's pretty diverse. And so you really can make a choice of the kind of tool that might be helpful to different kinds of people. And I think the ones that are incentive-based are actually really interesting. I haven't checked one out yet, but I do think that from behavioral, consumer and patient engagement, those have some really good opportunities.
I love how the panels really shifted gears into the app world, right? I mean, that's exactly where we're going with this conversation. So let's unpack it a little more. And I'd like to ask Dave a question, since you really have responsibility for enabling an ecosystem, right? Really bringing app development and innovation to the table. Question is just, as we think about apps supporting patient engagement, things like remote patient monitoring and some of the use cases we just discussed, like how do you see this all unfolding from a platform perspective, and how is the consumerism and apps really, coming to life given the regulatory environment and some of the innovation that you've been doing?
Yeah, I appreciate that. So yeah, I think to Lorraine's earlier point, that the thing that's really been huge from our perspective is the ONC 21st Century Cures Act. That's really moved the entire industry forward. I mean, HL7 always does great work, but this has really sort of focused the entire industry, not just on adoption of a particular version of the standard, but also sort of a key set, a baseline of resources and APIs that are necessary to make that standard and the information that can convey meaningful and solve real problems. So that's been hugely impactful for us in helping us get additional third parties on. So we support all administrations today. We have over 70 applications in production. Obviously, a subset of those specific to the health space and very varied. In terms of what we really view as important to in enabling this space is it needs to be easy, and there's multiple dimensions to that. It needs to be easy for organizations and application developers outside of VA. VA is a huge place if they try to approach it from a Q&A perspective or traditional, point-to-point integrations that'll just never scale and bring meaningful applications to our veterans. So we try to put things that are some of the best practices that we've seen in the CMS Blue Button program and in the commercial space in terms of self-service environments, really good documentation, really helpful aids in terms of building that application, and then also making it easy for the veterans. We do a lot of work making sure that the terms of service and the privacy policies that these applications present to those end users are really clear, and make sure that the veteran is in full understanding of just how that connection is going to behave. And then making it easy for the veteran to use the application. So enabling a single sign-on from an API perspective so that they can use their existing credentials for their patient portals to come in and connect to these APIs through third-party applications. And the login process is no different. Same username, password, same 2FA. So really making it easy from an end user perspective as well.
And I would share, from the perspective of developers as well. I was thinking about what Colonel Peck was talking about for, pediatric dental. I work on interoperability, security, privacy preservation. I'm never going to develop an app for kids with special needs who have dental requirements, right? But by using the open standards that we do, we really enable somebody who specializes in that, or maybe, somebody at a university who's really focused on that, to develop those apps that, an active service member or their family can start using with you, right? And ultimately improve their care. So I think, a big part of what we're all, promoting is this notion of open standards, not just because it makes it easier for us to work together, but it enables countless numbers of innovators who know things better than we do, because there's 10,000 domains within healthcare that we kind of gloss over as one. And it's really that specialization that we enable as well, that I think is a big part of what we're all doing.
Right. And just very quickly add on to what you're saying as far as the interoperability, in those special needs areas. And it could be something, on a senior side also.
Right.
When I have a service member that retires, I have to then transition his special needs child or out of our pediatric dental program to open space up for new service members that are coming in with the FNPs. And right now it is a very timely and cost intensive scenario to get them into Queens Hospital or someplace else downtown for care. Whereas to your point, if we had open sharing of records and some apps that assisted the patient in getting there, it would take a lot less effort and frankly, pain and stress off the patient, if we had that available.
100%. I think what Cerner is going to enable is, an active service member transitioning to the VA. How do we make that more facile and enable them to authorize the sharing of their data, not just with the VA, but also, their daughter-in-law or whoever they trust. Those things are not going to happen at, to Director Mazik's point, if we don't use open standards and if we don't document what we're doing, right? That's part of why we don't have interoperability today. The legacy technologies that we have were not built for that. So, kind of putting a line in the sand and saying, 2021 forward, let's all work on interoperable solutions.
Yeah, that's right.
Right.
Oh, sorry, Lorraine, go ahead.
Well, the only thing I don't want to lose sight of somewhere in our conversation is, and we're all talking about, the EHRs and I call them personal health records, because the one thing that we talked about, because I worked on a veteran suicide app at one point, or suicide prevention, was the usability and actionability of these tools, and whether it's the EHR for the provider side or the app, whether it's for the the caregiver or the patient, but the patient is at the center of all of this, and I know we're all talking about that, but we can't, if it's not usable, and so the standard language we're talking about, not just for the exchange of the data in the brain of the system, but that what comes out to the individual using that tool has to also be usable and actionable in order for it to work. And I just didn't want us to lose sight of that part of the conversation as well, as I was thinking about it.
And Maureen, you're saying both on the patient side and the provider and facility side, it has to be actual. So I pick up surveillance data on, let's just use it, COVID early on, because I have 5 different healthcare organizations inside of San Francisco or someplace. Maybe we get ahead of it and we don't end up in the the pandemic that we are. I know that's altruistic, but just as an example. And because you did bring up the app that you had worked on with brain injuries, so there's a site, it's called Brainline. We're doing a lot with apps when it comes to PTSD, depression, anxiety, etc. And to your usability point, the good thing about that is if I have a service member that is inclined to have one of those conditions, or frankly does, because they've already deployed once before, now they have an app that the provider has walked them through while they were back here in the States. And when they're downrange again, a lot of times they can self-manage and prevent something, or they know when it's time to reach back out to the provider because it's sitting right there in their smartphone, their personal smartphone. Exactly. So absolutely tremendous, movement forward on apps when it comes to things like that.
Yeah.
Like if we look back a decade ago, right, when we were trying to do interoperability at the document level, I can remember docs coming to me saying, I don't need any more data. I need information that I can act on. So we
Right,
were throwing
exactly.
400-page CCDAs at them and they were like, I'm never going to look at that, right?
Right.
So we've learned a
Exactly.
lot that, you know, that is incorporated into the standards and the tech that we're using. So that I can just say, here are the 400 blood pressure measures for this senior. And you don't need to see, you know, where it all came from if you trust the solutions we've built.
Yeah. And in the work we do at Cerner, right? Interoperability, the number of connections, number of documents, transactions, that's the metric of the past, right? It's usability. That's the next frontier of interoperability. And we absolutely need to be focused on user experience and especially consumer experience. And that really segues well. We have a couple of listener questions that I want to make sure we address. But no surprise that COVID is in the question. But just kind of reflecting on experience I had, if you looked at my biography, I'm pretty new coming back to Cerner. I was at Intermountain Healthcare in our community-based care organization. And I was actually responsible for overseeing our community testing as well as our early vaccine work. And a lot of the work we had to do was create a consumer experience on the fly. So to Aaron's point, right, without interoperable technologies underlying the work we were doing, it would have all just been paper-based, phone-based, et cetera. And it was for the first couple of months, but over time, it was just app developers, not just Cerner, but, Qualtrics and others that just kind of came to the table, really created a user experience based on user-based design, utilized underlying interoperable technologies, and created a flow for testing that we could test, hundreds of thousands of people over the course of several months, and then move those technologies into vaccines. So like that assembling of, these technologies for bespoke or really kind of focused use cases that are usable in the end for patients, that was really meaningful for the work we were doing at Intermountain. And the question from the audience is you get this question all the time, but how are our priorities changing as a result of what we're seeing with COVID-19, especially around public health and access to things like immunization records, where it's not just a CMS card, but something that's more digital and electronic. So maybe Lorraine, if you don't mind starting, we can talk about public health and apps in that domain.
Sure. Well, and there's one very significant task force. In fact, they're meeting now. I think they probably just finished. But it was based on an executive order, and it's under the ONC Health Information Tech, Health IT Task Force, looking at public health data systems and the communication, because unfortunately, public health is often underfunded, even though it's probably the most important infrastructure that we have in the country. But it's very massive, and it needs to be connected to social services and hospitals and provider offices. But in the pandemic, unfortunately, our shortcomings there were exposed. But there is a task force underway, and it was going to be meeting through the month of June to figure out, so what do we do so we don't end up there again? And they're doing a very robust set of meetings every week on that, and looking at the infrastructure and how they're going to be dealing with that. There is also an effort underway looking at, as I'm sure people have heard about, the COVID passport, the vaccination passport, digital ID cards. So there's a whole set of other initiatives looking at what can you have besides the card that you have. People have been questioning whether or not to laminate the card, because what if they have to get another booster shot next year? What will that do to the card? So there will be, additional evaluation of that. But suffice to say, there's a significant amount of work going on both through the White House Task Force, the CDC, and the Office of the National Coordinator on those very specific questions to make sure that infrastructure is buoyed up, and that communication comes out about that. I think the message is loud and clear about the significance of that, and some of the tools that had been in existence. There was something called an electronic case report that was in, I think, 12 states. And Aaron, you nodding your head, you know about that, of how can we leverage what was built and use that standard and make sure that it is applied everywhere.
The scanner project is some great work, right?
Mhm.
And I would say there's changing priorities and there's these continuous priorities, right? You know, even back before 20,000, right? 2000, trustworthiness, privacy, security, data quality, right?
Yeah.
All of those foundations are things that we will be working on forever. But I think once we start engaging the beneficiary, we'll be able to do a quicker turn on data quality, right? So even like, you know, work with some Medicaid programs and some programs that, you know, have data quality problems. Who's the person that's going to look at each one of the records, and how do we motivate them to look at those records? To one of your earlier points, Larry. You know, if we can incentivize my mom and dad to look at their Medicare benefits and confirm that they actually receive that care, just, you know, the impact on fraud, waste, and abuse would be significant.
Mhm.
All of those things become, you know, because we've been squeezing data since I had hair. I don't know if since Colonel Peck's had hair, but since I've had hair, you know, way back then. And it really comes down to who knows the data, who knows whether or not they went to see that pill mill and you know, got that opioid script, or is that somebody else getting that script? It's going to be the consumer. So I think,
Mhm.
you know, our changing priorities will always be changing, but our fundamental priorities have to be around trustworthiness.
Well, and to your point, and Maureen's earlier, so we're still running into significantly unique issues here on the island because the restrictions to get in and out of the island related to COVID
Mhm.
and the ROM requirements, et cetera. And so it's funny, in a situation like this, you learn how to leverage new technologies to help you. And at the same time, you realize some of our old technologies are still critical. And what I mean by that is, so obviously we went more virtual like everybody else did, and hopefully that will continue to do that. Although still the biggest remaining issue with the virtual piece is how do I code that properly? And the apps, the more that we get after them, and to your point, from a patient position and patient centric, it makes it easier with the virtual piece to take care of them without inconveniencing them. I.e., if I have a 82-year-old vet that lives on the North Shore that would have to make a 2-hour drive down to Tripler, the VA, maybe I can take care of his care or her care virtually that day, update their meds, et cetera, and they never even have to leave the house. Or they can call me and ask if they have to leave the house, and then I can send an ambulance to them. So I think from that aspect, COVID really assisted us. The cards and whatnot that you were talking about, Maureen, that the task force is working off of. One thing that frustrates me a lot of times in the healthcare setting from an IT standpoint is other industries have easy answers to our questions and we don't just take them. So, and what I mean by that is I have Apple Pay. I can open my door to my hotel room with a Hyatt, you know, at Hyatt. So why can't you simply give me a 2-factor authentication card that's on my smartphone and then we don't have to worry about reliability because the provider put it in and validated it, and to open it up, you have to have my thumbprint or my face, et cetera, or my password to get in and look at it. And I don't have to worry about losing it or laminating it or anything else. It's just already and it's available. And then just very quickly, so Tripler was built to withstand a Cat 5 typhoon or a 7.2 earthquake because of where it sits. So there is a ridiculous amount of extra concrete and rebar in the facility. So when COVID hit, the first thing that hit us was we couldn't contact almost any of our patients because nobody has a local number anymore. And we only had 24 long distance lines coming out of the facility. So we had to go all the way up to the Secretary of Defense, ASD, and ask for an exception to get another 100+ long distance lines put in so that our patients could reach us and we could reach them, because they all had long distance lines and we couldn't talk to them, and you can't use your cell phones inside the facility because we don't have a DAS solution. So sometimes there's just things that pop up that make you go old school that you wouldn't think that you would have to do. But I think we have tremendous, and I know we'll move into that later on one of the questions, tremendous opportunities from an apps perspective for patient experience and engagement and to reduce readmission rates and everything else. If we just take a little bit of a look at other industries and pull in what they've already done, especially like the hotel experiences or the casino experiences that you see.
Thanks.
Yeah, I could touch on the COVID piece a little bit too. So, I mean, in short, it changed everything. I mean, it really simple things that were really just hugely impactful. So like we already, given where we were with, moving towards O1C Cures, we support immunization data, but all of our patient facing data had 36-hour hold times on it, right? Because you always typically want the physician to be able to communicate with the patient ahead of the patient seeing something pop up on their app. COVID, we immediately put that to a 0-hour hold on lab results and immunization data. Things such as simple as facilities. So we had a process in populating facility data on a nightly basis, but literally on like 15-minute boundaries, facilities were closing, opening, limited service, limited hours. So we worked with our content management system team in VA to expose via APIs per hour information provided by the field. So essentially, rather than trying to centralize all that data in a single place, let the field drive the data, but then make it centrally available in an easy way, so that veterans weren't driving to facilities that were ended up being closed, or physicians are trying to contact physicians at other facilities. And then I guess lastly, we think about standardization and APIs opening up applications, outside of our organizations, but even inside. We were able to leverage FHIR APIs to really quickly stand up a clinical facing tool that our ER physicians will use in triaging COVID patients. So literally they were printing out PDF forms to go through sort of a checklist in treating patients in the ER that were potentially COVID positive. And now that can just be a digital solution, right? So obviously you can just imagine the huge improvement in the encounter in both time and accuracy that APIs and standardization enabled inside the organization, and in addition to the classic case we're talking about of outside with patients.
As a data scientist, right, we're looking at the data and we're starting to see the measurable impacts of the health inequity that we have in our country as well, right? Via the COVID data that we have. We're seeing some of the barriers to effective social services and community-based organizations and VSOs, right? Being able to help us all improve what we're doing. So I think, I guess the question I was trying to answer is, how did COVID change the way you really view the world? It's become very stark, at least to me, that a lot of things that are not in your control determine the outcomes that you receive and the care that you can get to, right? And that's not how our country should work, in my opinion.
Oh, just to kind of touch on that a second, and I have to be really sensitive when I say stuff because of my position. But back to what Maureen was talking about earlier, the task force. Of course, when we went into the whole government approach, there's active duty service members in New York and Seattle, and now they're all over the place helping, give COVID shots. I think I have 11 people out of AAA right now that are in CONUS on teams, giving vaccines. And so to your point, there is absolutely zero interoperability from a public health standpoint or surveillance standpoint between the states to state, or state to federal, or federal to another federal agency. And so if we learned anything, and the task force is going after anything other than figured out how to get somebody, validation that they've had their, vaccinations in a repeatable format that doesn't get destroyed, there really should be one central database from that surveillance standpoint that allows us obviously to strip out everybody's HIPAA and PII, et cetera. So Big Brother kind of thing isn't looking at you. But maybe have we had something like that early on? And I know it's sensitive, but maybe when New York started sending their elderly patients into homes, and the death rates went through the ceiling, Illinois and some of the other states would have very quickly pulled back and not done it at all. But there's just no database out there that allows us to track that and execute in a timely manner. And I can only tell you the pain of trying to figure out how we're going to document the shots or the care that we provide on this whole government approach, because we would go in with our electronic systems to give shots and then provide those back to the local organization or county or whatever. And they'd like, oh, no. We have a stack of papers over here. This is the only way we do it. And then the state would come in and go, well, your stack of papers is the wrong stack of papers because we moved to this form last year. And it was an incredibly frustrating and painful experience, and did the patient or the providers absolutely no good.
So much we could talk about there, right? Like even kids, we create programs to help people, right? Vets and social services, but to get qualified for them, there's this burden on the consumer and the provider and the social worker just to document it properly, right? There's been huge programs that we've created just for autistic families, that because it took so long to get the kids qualified from the right docs with the right, diagnosis, we didn't spend half the money, right? It just doesn't, one set of policies is counteracting another set of policies, and we don't make the progress we could if we all got a little better at using open standards and sharing data.
Yeah, to that point, let's talk about maybe the big picture a little bit, kind of national lens, maybe the information blocking and with the 21st Century Cures CERT regulations, have really made a platform for innovation, right? I mean, the work done is not, it doesn't really stipulate, these are the apps, here's how you're going to serve your patients. This is the data, it's going to be available, here are the standards. Let's see what happens, in a sense. I'm just curious from your lens, when we talk about these FHIR servers that are sitting on certified health information systems, as well as the information blocking rules, what does that mean in terms of curating a longitudinal record for a patient? One, that, is that the future? Is that where we're going? And how does, how do you see, these rules and this landscape really coalescing around the patient at scale, at the national scale? Anyone who wants to take it can take it.
So I'll throw out a story that I think will help other people contribute to, right? So, a decade ago, my son had 9 PHRs, right? That I just couldn't keep track of myself, right? And today, even without my wife's help, I'm certain I couldn't repeat to you who are all the providers he's gotten care from. But when I get his, through my employer, from the commercial payer, pay claims information, I get a treasure map of where he's gotten care. And that will help facilitate my directory discovery. This doc works with Cerner. He's using Cerner. Here's his electronic endpoint. And this doc is using OneRecord, and this doc is using, Patient Ally or whatever they're using. Without that treasure map, I'm not going to be able to, tell you what happened this year, let alone over the last 10 years. And I think, when you look at active service members moving around the country, I couldn't remember where, before you were in Hawaii, like what were the 4 docs that your family saw? I just can't picture without the aid of what the EOB was originally intended to help, right? So now that we have an electronic directory of, or an electronic record of at least the care that's been delivered, and we can start to discover where the clinical information is. Now I can facilitate my consumers, my end users, my customers' to actually get that data without spending 30 hours a week maintaining.
I will raise you one in sort of a different part of the conversation. Just to add on to that, because there's sort of 2 things I wanted to say. And I don't know how many of you participated in the WEDI conference this morning, but Mickey Tripathi actually spoke at that, and he talked about information blocking. And one of the things that I love that he said is that their rule turned the concept of information blocking or access to data on its head. And what I took away from it is that now the answer is yes, in terms of, can I have my data? Which I really love, because in so many instances when patients have asked for their data, whether it's been from a provider or a payer, it's like, well, because of HIPAA, I have to check, and you've got to sign this, and it's been very complicated. And what information blocking has said essentially is, yes, you can have your data. And that's really the intent of any of the rules before wasn't to prevent people from getting access to their data. So now you can get your data. Naturally, privacy and security provisions are all critically important, but we have to do it within reason of getting people the information that they need. And that sort of being practical about that, because you do need to have your information. We're beginning to solve the problem of the standards, and we have Cerner here, and Cerner needs to be able to talk to Epic, who needs to be able to talk to the next one and the next one. And we're beginning to solve that issue. And now through the CMS rules, we're beginning to solve the issue of the patient being able to take their data with them from payer to payer, so that longitudinal record that Sam was asking about is that I don't have to chase my information for year after year, that I can, to the extent that a payer has any clinical information, and eventually, perhaps it'll be claims information also, that I'll have this record and I won't have to remember what happened to me. I'll be able to have it. So if I change, well, for Medicare, it would be, if I'm fee for service Medicare, then I go to Medicare Advantage, then I might transition back, but you'll have that whole perspective. So you'll have your clinical records with the EHR, and you'll have it from a payer perspective. So you'll have this body of knowledge that'll help your provider take care of you as well as your payer, which will reduce duplication of services. It'll help with prior authorization. It'll help with case management.
Yeah, and just to add to that, the longitudinal piece. So in 2007, I was the chief information officer for Iraq and Afghanistan and Qatar, and which is when we deployed the first electronic health record in theater that also include the inpatient piece and the PLX, as far as it being transmitted within 2 hours of the time that the care was provided wherever in theater. And one of the real keys with that was we were literally opening patients back up at Landstuhl when they landed in Germany, because we had no idea what we had done to them when they were in Iraq, because of early on in the war, the lack of lines of communication, et cetera. And once we got that all stood up in 2007, that all went away, to the point where as the patient came off the plane, they knew what facility they were going to, what ward they were going to, if they were expectant, if they were immediate, et cetera. And so that's kind of an extreme, obviously, case, but it just talks about the tremendous benefit of having that true longitudinal record that you can see as you move throughout the system. And so even today with our old system of CHDS and Alta, when I get out of the service, I will have a complete longitudinal health record.
Wow.
I have everything that I ever had in there. However, to his point earlier, as I've gone from location to location, some locations I had to take my images with me and then get them downloaded again. Some locations I actually had to carry my entire health record with me. And a lot of what's done on one site isn't available at the other site until they go up, reach for it, and pull it down after asking permission to get it. Once we move fully into Genesis across DHA, Cerner, then that won't be an issue. With that comes some challenges that are, amusing somewhat, is if you don't do your naming conventions right, I'm going to have a doc and tripler trying to print a label out for his patient, and it prints out in Landstuhl in Germany because we didn't properly name their printers and tie them to the the system and the provider local. So just, little things like that. But absolutely, the ability to see it across will help the patient so much. The other nice thing about the Cures Act piece of the blocking is it centers on the patient vice the technology. So before we were saying, you will do this, you will do that. Providers, you will check a block to say that you actually did this, but the patient wasn't in charge and it wasn't centered around getting the information to the patient. And now providers and facilities, if they just check a block, aren't going to get full credit for the care that they're providing. So, you know, it's a little bit like the carrot and the stick. You have to incentivize everybody to jump in, because I won't mention the name of one of the other EHR companies, but she is very, 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 very protectionist of her EHR and their data. And so you're going to have to incentivize companies like that to fully jump in with the interoperability piece, which I think this new language in the CARES Act gets at more so to pull people along that initially didn't want to get pulled along.
Well, Colonel Peck, that was fantastic remarks and just really great perspective. I'm going to have to, unfortunately, draw this conversation to a close given the time, but I know we could have gone on for hours and hours. This has just been such an enriching dialogue. I want to thank the panelists, Lorraine, Colonel Peck, Dave, Aaron, for the participation and the diverse perspectives, the policy perspective, the DoD, the VA, you know, the platform, the app developer. I mean, we had a really nice dialogue, and hand it over back over to Mandy to close us out. And thank you.
Thank you guys so much. Yeah, I just wanted to add my thanks as well, especially for those of you that got up early or found out about this last minute. Really appreciate everybody's involvement. This was a great discussion. We should have made this a 2-hour long panel to get through all the other questions that we had that had been prepared ahead of time. But this was fantastic, and really appreciate all of your support for this event and just supporting HIMSS NCA in general. And for our attendees, thank you so much for joining and for your engagement and questions. We really appreciate it. And please be on the lookout for our summer events, as well as Dan Bloom's email that I mentioned. They'll be coming out to our members. So thank you all again, and